Case number 3. Mr. G is a 36-year-old Hispanic male presenting with complaints of a persistent cough for the past 3 months. He reports night sweats but is unsure if he has had fevers due to not taking his temperature. He reports feeling fatigued but has started a new job within the last 3 months in a warehouse with high temperatures and has experienced a lot of overtime. He believes this might all be allergy related and reports a stuffy nose. He also reports occasional shortness of breath with exertion. He states that he has a dry cough with occasional clear sputum, and his cough is not getting better, but it is not getting worse either. Mr. G has a history of allergies and a history of asthma as a child, which he states he grew out of. He also has a history of hypertension. At this time, he denies any nausea, vomiting, diarrhea, constipation, or heartburn. He has a family history of hypertension and asthma. His maternal grandmother has type 2 diabetes, and his mother has migraine headaches. He was born and raised in Mexico, but says he is from Texas. He lives with his girlfriend, her 2 children, and their child. He has a history of smoking about a pack per day since the age of 16, but states he quit about 6 months ago. He has not had any known exposures recently to contagious illnesses, including tuberculosis. His medications include lisinopril 20 milligrams per day. Upon physical exam, his weight is 180 pounds, height 5 foot 11 inches. Temperature was 99.2, pulse 72, respirations 18, and a blood pressure of 134/84. He denies chest pain or wheezing. His nasal turbinates are gray and boggy. His pharynx is with clear postnasal drainage. No sinus tenderness or lymphadenopathy. His lungs are clear to auscultate. His heart is regular without murmur or gallop. His abdomen is soft, non-tender, and he has no peripheral edema. Differential diagnoses may include allergic rhinitis, exposure to irritant, and asthma. Allergic rhinitis is highly likely due to his symptoms and his environmental changes. The symptoms of gray and boggy nasal turbinates as well as clear postnasal drainage. Also likely would be the exposure to irritants. He might not have been exposed to any known tuberculosis, but he did start a new job in a hot warehouse where he could have been exposed to any type of new irritant there. And then there is asthma, which is less likely. The patient does have a history, but his symptoms do not match. He has no wheezing at this time, no chest pain, or no other symptoms of asthma. The most likely diagnosis for this patient at this time would be allergic rhinitis, due to his gray and boggy nasal turbinates, the presence of clear postnasal drip, a low-grade fever, recent environmental change, and temperature changes, as well as nasal congestion. Diagnostic testing that may be performed would be a nasal smear, lab work, and allergy testing. The nasal smear would be to rule out infection and presence of eosinophils. Lab work may include a CBC and a BMP, and these may be drawn to see a baseline for the patient and rule out possible infection. Allergy testing may be performed using skin testing to confirm allergic rhinitis diagnosis. An IgE and a RAST blood test may be completed. These tests may be completed to measure the specific IgE antibodies to help establish the diagnosis of the allergic disease by identifying which allergies are causing the symptoms of hay fever or asthma. Further questions for the preceptor may include: do you agree with my diagnosis? And do you agree with my diagnostic testing? What other signs and symptoms might you be looking for? What would you suspect to be the cause of the complaints. What other testing might you conduct, and what might be your next step? Case number 2. Mr. D is a 59-year-old male who presented 3 weeks ago with complaints of allergies and a lump of phlegm in his throat that he just could not shake. He was given Flonase and was instructed to follow up in 3 weeks. It has been 3 weeks and now he is back with complaints of dysphagia. He is able to swallow liquids but reports difficulty eating meat. He states he has to chew each bite forever in order to get it down, and sometimes he reports it still gets stuck. He reports having lost weight as well as having fatigue. Mr. D is incarcerated. He reports having an EGD about 10 years ago for recurrent GERD, but no abnormalities were found as far as he can recall. His history includes frequent GERD, type 2 diabetes, which he states is controlled, as well as hypertension. He had an appendectomy at age 14 and multiple gunshot wounds at age 29. At this time, he has no complaints of nausea, vomiting, diarrhea, or constipation. He states that his GERD flares up 2 to 3 times a week. He has a history of significant alcohol intake over many years, and he is a 45 pack per year smoker. His current medications include over-the-counter Zantac for his GERD. He used to take Prilosec, but it is no longer on the prison formulary, and he does not have the money to buy it. He also takes metformin, lisinopril, and Hytrin 2 milligrams at bedtime. Upon physical exam, his weight is 169 pounds, height 5 foot 10 inches. Temperature was 97.8, pulse of 68, respirations of 20, and a blood pressure of 116/78. Mr. D is alert and in no apparent distress. His HEENT are unremarkable. His lungs are clear, heart rate, regular rate and rhythm, without murmur or gallop. His abdomen is soft and non-tender, with positive bowel sounds in all 4 quadrants. No edema is present, and his pulses are 2+ throughout. Blood work showed a normal chemistry panel including liver and kidney function tests, and his A1C was 6.4% 2 months ago. Differential diagnoses that may be included are GERD, Candida esophagitis, and esophageal obstruction or tumor. GERD is highly likely due to his history and symptoms. The patient is a smoker and drinker. He also has had medication changes that may have produced more room for flare-ups. Next would be Candida esophagitis, which is also likely due to his history. He is also a diabetic, on Flonase, and he has a social history of smoking, which leads him to be more susceptible to Candida. And third would be esophageal obstruction or tumor. This would be to his dysphagia with solid foods and being able to swallow liquids, as well as his social history. At this time, the most likely diagnosis would be GERD. I believe GERD is the diagnosis due to his generally unremarkable physical examination, his tobacco and alcohol use, his history of GERD with numerous flare-ups, and the medication usage. A diagnostic testing that could take place would be an upper GI. An upper GI would be used to rule out any type of Barrett's esophagus, Candida esophagitis, and possible obstruction. He had an EGD 10 years ago, but a follow-up EGD may be needed. This EGD may be needed to view the esophagus to detect lesions, varices, ulcers, or tumors. Biopsies can be taken and sent out for further diagnoses if necessary. Further questioning from my preceptor would include: what would you suspect to be the cause of Mr. D's complaints? Do you agree with my diagnosis and my diagnostic testing? What other signs and symptoms would you look for? What other testing might you conduct? And what might be your next step or the next plan of care for this patient? Case number 1. Mrs. M is a 52-year-old female presenting today with increased fatigue that has kept her from going places or doing anything. She also complains of increased back pain that has made it difficult for her to do the dishes. She also reports panic attacks. During her panic attacks, she reports being short of air, has palpitations, shakiness, and sweatiness. She states these panic attacks last 5 to 15 minutes, and after they resolve, she finds herself to be exhausted. She admits to urinating small, frequent amounts and feels urgency to void. She reports this urgency has been going on for a couple of years, but believes it is getting worse. She also reports weight loss and a decreased appetite, although she feels she is still eating just as much, stating she might not be, but she cannot tell. Mrs. M has a history of depression for 10 plus years. She was previously taking Prozac 20 milligrams a day for her depression, but has switched to Cymbalta a year ago due to her chronic back pain. She reports that her depression has been worsening over the past 3 months. She has a history of gestational diabetes, and her blood sugars are being followed at the office and have always been normal. Her weight at her last office visit was 129 pounds, and she is now 119 pounds. She has never been hospitalized for psychiatric reasons or reasons other than her appendectomy in 1992 and her cholecystectomy in 2000, or her childbirths. She has never had high blood pressure. She denies nausea and vomiting. She denies chest pain except during her panic attacks. She denies dizziness, and she reports being irritable often. She also denies diarrhea or constipation. She gets occasional headaches relieved by Tylenol, as well as intermittent indigestion and occasional back flare-ups. Mrs. M is widowed. Her husband died 3 years ago. She owns her own home and has 2 adult daughters that live nearby. She was a stay-at-home mom and has not worked since her youngest daughter was born. She used to babysit her grandbaby in the mornings, but states that she gets too nervous to do that anymore. She drinks a Mountain Dew and 3 cups of coffee per day. She denies any street drugs, and she does not smoke. She also states that she does not exercise regularly. Her current medications include Cymbalta, Tylenol and Advil as needed for back pain, Zantac over-the-counter 2 to 3 times a week for intermittent indigestion, and muscle relaxers as needed. Her last Ultram prescription was for 30 pills, and this was for 3 months ago. Upon physical exam, her weight was 119 pounds, height 5 foot 3 inches. Temperature was 99.2, pulse was 94, respirations 22, blood pressure 128 over 82. She appears anxious and speaks rapidly. A fine tremor was noted. Her eyes, nose, and throat are normal. No nodules are palpated, but a possible slight fullness is noted in her neck, but may need further investigation. Her lungs are clear, heart rate rapid but regular without murmur. Her abdomen is soft, non-tender, with positive bowel sounds throughout. Pedal pulses were 2+ bilateral with no peripheral edema. Her differential diagnoses include depression, which is highly likely due to her history, her social history, and symptoms. The patient is having limitations with her ADLs, which would cause an increased depression. Anxiety, likely due to her history and symptoms. The patient is experiencing panic attacks due to her decreased ability to function as she once did, as well as dietary changes. Dietary changes is a likely differential diagnosis, and this is due to her poor appetite and increased consumption of caffeine. Another differential diagnosis may include seizures, which is less likely, though the patient has noted tremors, but they could be caused by her caffeine intake. For this patient, the most likely diagnosis would be depression. Depression would be the diagnosis due to depressed mood, appetite disturbance, fatigue, increased complaint of pain, and intermittent gastric reflux. Her recent medication change could be making her symptoms worse. Diagnostic tests that could be done be laboratory studies are not diagnostic for depression, but can be used as a guide to rule out other issues. Such tests would be a CBC, thyroid levels, BMP, and vitamin B12 levels. An EEG may be ordered to help identify a focus of disturbance in the brain and possibly rule out seizures. CTs or MRIs may be used to visualize the anatomic structure of the brain. Further questions for the practitioner may be: are there other signs and symptoms that you would look at? What further testing might you order? What might be the next step in your plan of action? Would you include a specialist? If so, what specialist might you send this patient to? And would you agree with the diagnosis and diagnostic testings that I have chosen?